Welcome back to our series on heart failure. In our previous sketch, you learned all about the clinical features of chronic heart failure. In this sketch, we'll review what to do about it. So let's leave the land of mermaids and mermen behind, head up to the surface, and check in with this human love story as these young lovers celebrate their matrimony Southern style, while floating down Old Man River. Here's to the bride and groom, and here's to hoping all this heartbreak drama doesn't wreck their special day. Anywho, before we jump into the plan, let's recap the clinical presentation of heart failure with our sample assessment from part 1. Mr. Clemens is a 64-year-old obese man with hypertension and diabetes presenting with 3 months of worsening dyspnea on exertion and progressive lower extremity edema. He now has shortness of breath walking around the house, but does not have symptoms at rest. Physical exam is notable for pitting edema of the lower extremities, elevated JVP, and an S3 gallop. Labs are significant for a BMP of 470. Chest X-ray is significant for cardiomegaly and pulmonary edema. TTE reveals LV hypertrophy, severe LV diastolic dysfunction, and an EF of 55%. These findings are most consistent with NIHA Class 3 heart failure with preserved ejection fraction. Great! Now that you're familiar with the clinical presentation of chronic heart failure, let's dive into what you can do about it. Here on the Mississippi, and everywhere else, heart failure is represented by our recurring sketchy symbol, the floppy heart balloon. As you might remember from our last sketch, heart failure can be divided into 2 major pathophysiologic categories: heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. This distinction is super important since many therapies that are effective in treating heart failure with reduced ejection fraction aren't necessarily effective for heart failure with preserved ejection fraction. Before you start prescribing drugs and devices, however, the first step is to appropriately stage your patient. By that I mean using the American College of Cardiology Foundation and American Heart Association's heart failure staging system, which categorizes patients based on their history, exam findings, and echo results. Hence the American flag flying triumphantly from the top deck of this riverboat. Riverboats and weddings. This is America. Note that this staging system is separate from the NYHA functional classification that we reviewed in part 1, which stratifies patients based on the severity of their symptoms. The ACC FAHA staging system divides heart failure into stages A through D. In this sketch, each stage is represented by a level on this riverboat. Keep in mind that we're talking about staging, so once patients reach one stage, they can't go back to an earlier stage. This system was designed to reflect the progressive nature of heart failure. Without further ado, let's embark on our journey through the management of chronic heart failure one stage at a time. Let's start with, where else? Stage A, represented by the top deck of this riverboat. Stage A encompasses patients at high risk for heart failure, represented by the red dice for risk, but without actual structural heart disease or symptoms. Hence a recurring happy asymptomatic guy. I know it kind of sounds like these patients don't have heart failure, but hey, that's what stage A is all about. As you might expect, management of patients with stage A heart failure focuses on controlling their heart failure risk factors. That's why we've drawn the ship's control panel up here on A deck. Major risk factors for heart failure include hypertension, represented by our recurring sketchy symbol, the steam coming out of this angry guy's ears, obesity, represented by this larger man, hyperlipidemia, represented by that yummy stick of lipidy butter he's holding. Now I know we're in the South. Diabetes mellitus, by that jar of Diasweeties candies, and tobacco use. In addition, cardiotoxic medications, such as doxorubicin, represented by a recurring heart-shaped box of rubies, should be avoided if possible. Moving on. Stage B includes patients with structural heart disease. Commonly left ventricular remodeling, hence the remodeling of that structural damage on B deck, but without signs or symptoms of heart failure. Which is why this guy is still happy. Don't forget, structural heart disease also includes a history of myocardial infarction, represented by a recurring sketchy symbol, the heart-shaped guitar with a broken string, as well as asymptomatic valvular disease, represented by this happy band member's broken saxophone valve. These fellows are fixin' to have quite a shindig. They don't even care about their instruments falling apart. Now that we know who stage B patients are, let's talk about their management. Treatment of stage B heart failure is focused on preventing the development of heart failure symptoms and reducing mortality. For starters, everything we do to control risk factors for stage A patients also applies to stage B patients. After that, take a look at your patient's ejection fraction. That's because patients in stage B heart failure with reduced ejection fraction, aka HFrEF, will benefit from a few really important medications. This brings us to our happy groomsman. This guy is feeling great despite his falling cake fraction, our recurring sketchy symbol for reduced EF. In patients with HFrEF, ACE inhibitors can prevent progression to symptomatic heart failure and reduce mortality, which is why every patient with stage B heart failure and reduced ejection fraction should be on an ACE inhibitor. ACE inhibitors are a huge mainstay of heart failure therapy, hence the huge ACE card on the deck of this ship. The benefits of ACE inhibitors hold true for all stages of heart failure with reduced ejection fraction, so they should be started once a diagnosis of reduced ejection fraction is made and continued indefinitely. One word of caution for all you careless cake droppers. ACE inhibitors are known to increase levels of bradykinin, which can lead to the classic side effects of cough or angioedema. For patients who can't tolerate ACE inhibitors, angiotensin receptor blockers, aka ARBs, can be used instead. For all the details on the pharmacology of ACE inhibitors, check out our dedicated ACE inhibitor sketch in Sketchy Farm. Next up on the HFrEF hit list, beta blockers. In patients with HFrEF, beta blockers, specifically carvedilol, metoprolol, and bisoprolol, can prevent progression to symptomatic heart failure and should be started in all patients with stage B heart failure and reduced ejection fraction. At Sketchy, beta blockers are represented by our recurring symbol, the muted beta bugle played by this jack card. A gambling riverboat? Mark Twain would be proud. Carvedilol, metoprolol, and bisoprolol are the three beta blockers shown to be effective in the management of heart failure. Hence our beta blocker jack holding a carved metal shield with an image of a bison on it. We know ACE inhibitors and beta blockers are great for patients with HFrEF, but they're especially useful in patients with HFrEF and a history of ACS, as they've been shown to significantly reduce mortality in these patients. That's why the last card on our deck, right next to the ACE and beta blocker jack, is of an angel, our recurring sketchy symbol for mortality reduction, playing a heart-shaped harp with a broken string, our recurring symbol for ACS. Also note, in heart failure patients with a history of ACS, statins should be used to prevent progression to symptomatic, that is, stage C, heart failure. Statins are represented by our recurring sketchy symbol, the steampunk pirate, gleefully hanging from the ship right next to the broken heart-shaped guitar string. Sorry, guy, the steam-powered ship doesn't fly, but good for you for having a good time anyway. Let's move on to stage C heart failure. We'll be covering a boatload of therapies in this section, so hold on tight to that wheel and let's navigate this river of knowledge together. Down on C deck, things are really starting to get complicated. Stage C includes patients with structural heart disease and prior or current symptoms. If that happy guy up there on B deck is our symbol for an asymptomatic patient, then this unhappy bride is naturally our symbol for symptoms. Stage C is what you typically think of when you hear the phrase heart failure, as it represents the stage when the classic symptoms of heart failure manifest. Since the ACCF-AHA heart failure stages are progressive, meaning there's no going backward, it stands to reason that treatment is progressive too. Therefore, everything we've talked about in stages A and B also applies to patients in stage C heart failure. Controlling risk factors such as hypertension, obesity, and diabetes is critically important in patients who already have heart failure symptoms to improve their quality of life and survival. Just like stage B, the management of patients in stage C heart failure also depends on the LV ejection fraction. Let's start with management of stage C heart failure with reduced EF, which will be the main focus of this section. Reduced EF is once again represented by falling cake, this time knocked into the Mississippi by a startled bridesmaid. I do declare, this wedding party needs to get it together. As was the case in stage B, ACE inhibitors, ARBs, and beta blockers should be used in all patients with stage C HFrEF to decrease morbidity and mortality. That's why we've drawn a staircase leading from C deck to B deck, specifically the ACE and beta blocker jack cards. Speaking of which, remember our old friends, the ARBs, which we can use as substitutes for ACE inhibitors? Well, here's an exciting new twist on them. Valsartan subcubitril is a new drug that was approved for heart failure in 2015. It's the first of a new class of medications known as angiotensin receptor neprilysin inhibitors, or ARNIs, represented by this carnival banner. Carnival season in New Orleans? Now it's a party. Patients with stage C HFrEF who tolerate an ACE inhibitor or ARB should be switched to an ARNI to further reduce morbidity and mortality. As you can see, ARNIs are quickly turning into the drug of choice for HFrEF patients with symptoms. ARNIs combine an ARB, like valsartan, with a neprilysin inhibitor, such as sacubitril. Neprilysin is an enzyme that degrades natriuretic peptides like BNP, which is why we've drawn in our recurring sketchy BNP blimp towing along the carnival banner. Just like ACE inhibitors and ARBs, ARNIs are also associated with hypotension, renal insufficiency, and angioedema as side effects. That's why patients have to tolerate those drugs before you switch them to an ARNI. Next up on our HFrEF hit list is an old favorite, aldosterone receptor antagonists. The aldosterone receptor antagonists, eplerenone and spironolactone, can improve mortality in patients with stage C HFrEF who have symptoms limiting activity. This is illustrated by our angel bridesmaid using her spiral spironolactone notebook with an eplerenone apple drawn on it to block the splash from the crystal chandelier, our recurring sketchy symbol for mineralocorticoids. As you might remember from Sketchy Farm, the major side effect of aldosterone antagonists is hyperkalemia. Therefore, make sure you check your patient's potassium level before starting these agents. Aldosterone antagonists, beta blockers, and ACE inhibitors, ARBs or ARNIs, are the drugs you'd give to almost every patient with stage C heart failure and reduced EF. This next therapy, however, is reserved for a smaller subset of patients. The combination of hydralazine and isosorbide dinitrate decreases morbidity and mortality in some African American patients with stage C HFrEF, specifically those who have significant symptoms despite optimal therapy with ACE inhibitors, beta blockers, and aldosterone antagonists. You can see that despite all the therapies we've discussed, this bridesmaid is still short of breath. Time for her to escape on that nitro-powered hydroboat. Before you start thinking that we only throw drugs at heart failure patients, let's talk about implanted cardiac devices. Cardiac devices, such as implanted cardioverter defibrillators and pacemakers, represented by the metal heart pin on this unfortunate maid of honor, can improve mortality in some patients with stage C HFrEF. Let's start with ICDs. These little zappers are recommended for primary prevention of sudden cardiac death, represented by this maid of honor suddenly falling into the water, in certain patients with HFrEF and symptoms who are on optimal medical therapy. Next up, pacemakers, aka cardiac resynchronization therapy, are recommended for patients with stage C HFrEF and symptoms on optimal medical therapy who have ventricular arrhythmias that result in a prolonged QRS duration, such as left bundle branch block. Hold up. You might have noticed two big therapies that we haven't touched on yet, diuretics and digoxin. These two classes of medications don't provide a mortality benefit in patients with heart failure, but are still frequently used because they can improve symptoms and quality of life. As we discussed in our last sketch, most chronic heart failure symptoms, such as dyspnea and peripheral edema, are due to fluid retention. That's why we've made our angry, symptomatic bride sopping wet and totally volume overloaded. What a day for her. When patients with heart failure have symptoms of volume overload, loop diuretics, represented by the looped tiara and the bride's unseemingly trickle of water from her dress, are fast and effective. Therefore, all stage C heart failure patients with evidence of fluid retention should receive loop diuretics such as furosemide or bumetanide for symptomatic relief. While you can and should use loop diuretics in patients with heart failure and preserved ejection fraction, extra caution should be taken since these patients are more dependent on preload to sustain cardiac output. Once again, diuretics have not been shown to improve mortality in heart failure. They are only used for the treatment of symptoms. Notice that, unlike her bridesmaids, our bride is no angel, though she does have every right to be furious about her ruined Vera Wang dress. Loop diuretics aren't the only game in town, however. Thiazide diuretics, such as hydrochlorothiazide and chlorthalidone, represented by a recurring sketchy symbol, the white chlorothies on this pantsless waiter, are good options for heart failure patients with mild fluid retention and concurrent hypertension since they have stronger antihypertensive effects. Hence the steam coming from this angry waiter's ears. As they say in the South, this poor fella's madder than a wet hen. Yeah, idioms are weird. Digoxin, illustrated here by the bride's foxglove, aka digitalis bouquet, is a positive inotropic agent used for symptomatic relief in HFrEF. While it hasn't demonstrated a mortality benefit, it has been shown to reduce hospitalizations. Consider adding digoxin if your patient remains symptomatic despite optimal therapy with an ACE inhibitor, beta blocker, and diuretic. In addition, sodium restriction is reasonable for patients with symptomatic heart failure to reduce symptoms of hypervolemia. At Sketchy, we've represented sodium restriction with these falling salt shakers, dropped by our angry, pantsless waiter. Keep in mind, though, that while sodium restriction is common in practice, it's not well supported by current evidence. Whew, what a list! But we're not quite done yet. Let's move on to heart failure with preserved ejection fraction. Unfortunately, therapies effective for heart failure with reduced EF haven't shown similar results in patients with heart failure with preserved ejection fraction, aka HuffPuff, represented by this preserved cake fraction. The only thing we can really do for patients with HuffPuff is to treat their symptoms and control the underlying conditions most responsible for diastolic dysfunction. First and foremost, this means aggressive blood pressure control, represented by this patched up steam pipe. ACE inhibitors, ARBs, and beta blockers are the first line options here. Next, if your HuffPuff patient also has AFib, make sure that's controlled too. Uncontrolled AFib can worsen heart failure symptoms in patients with diastolic dysfunction due to loss of the atrial kick, a major contributor to diastolic filling of a stiff left ventricle. Finally, patients with stage C HuffPuff should also receive loop diuretics if they have evidence of volume overload, such as crackles, elevated JVP, or peripheral edema. As is the case in patients with reduced EF, diuretics only improve symptoms, not mortality. Finally, let's tackle stage D heart failure. Stage D is the most severe stage of heart failure. It's so advanced, it's not even on the boat. We're waist deep in the old Mississippi now. Patients in stage D heart failure have refractory symptoms at rest despite being on all the therapies we've discussed for stage C. Our groom represents this stage of heart failure. Look at him, completely soaked from having fallen into the river with all his medications floating around him in the water. Patients in stage D heart failure typically struggle with symptoms of volume overload, so fluid restriction, to around 2 liters per day, is reasonable to reduce congestive symptoms. Hence our keep out of water sign on the riverbank. Despite the treatments we've discussed, many patients in stage D heart failure will still have symptoms. Thankfully, there are treatment options for eligible patients in stage D, including ventricular assist devices, aka VADs. VADs, represented by the funky pack worn by our groom, can improve mortality in carefully selected patients. Notice how it's hooked up to the heart-shaped design on his shirt? Last but not least, cardiac transplantation is indicated for carefully selected patients with stage D heart failure. Getting a transplant isn't easy, but hey, neither is falling in love with a freshwater mermaid in the bayou. Uh-oh, it looks like we're in the middle of a good old-fashioned love triangle. Anywho, a detailed discussion of these advanced therapies is beyond the scope of this sketch. Just remember to keep these last resorts in mind if you're taking care of a patient in stage D heart failure. Awesome job! Rolling down the river of heart failure management can be confusing, so let's recap what we've learned. The management of heart failure is contingent on the particular stage of heart failure your patient is in. So the first step is to use the ACCF AHA staging system to determine whether your patient is in stage A, B, C, or D. Stage A refers to patients who are only at high risk of heart failure, but don't actually have structural heart disease or symptoms of heart failure. For these patients, controlling their risk factors for heart failure, such as hypertension, obesity, and diabetes, to name a few, to prevent structural heart disease is the mainstay of therapy. In stage B, patients have documented evidence of structural heart disease, most commonly a reduced left ventricular ejection fraction, but don't have any symptoms or signs of heart failure. For these patients, and indeed all patients with reduced EF, the 2 biggest drugs we use to halt the progression of heart failure are ACE inhibitors and beta blockers. Additionally, statins should be started in patients who have a history of acute coronary syndrome to prevent progression to symptomatic heart failure. Once we get to stage C, things get a little more complicated. That's because stage C is technically where the clinical diagnosis of heart failure is actually made. These patients have both evidence of structural heart disease and active or prior symptoms of heart failure. For patients with stage C heart failure and reduced EF, the main drugs shown to improve mortality are, once again, ACE inhibitors and beta blockers. For patients with stage C heart failure with reduced EF who have symptoms with activity, that is, NIHA class 2 or 3, switch them over to an ARNI to further reduce their morbidity and mortality. In addition to these drugs, patients with stage C heart failure with reduced EF and symptoms limiting activity add an aldosterone receptor antagonist to improve morbidity and mortality. One last pharmacotherapy that's been shown to decrease mortality is the combination of hydralazine and isosorbide dinitrate. This therapy has only been shown to be effective in African American patients with significant activity limitation despite optimal medical therapy. These are the only drugs that have been shown to have a mortality benefit in heart failure with reduced EF, but they aren't the only drugs we use. Loop and thiazide diuretics, along with sodium restriction, are commonly prescribed and can improve symptoms, but not mortality, in patients with stage C heart failure and evidence of fluid retention. Digoxin can decrease hospitalizations in patients with heart failure and reduced EF, but offers no mortality benefit. All of these drugs so far have only been shown to help patients with heart failure and reduced EF. When it comes to patients with stage C heart failure with preserved EF, no drugs have been shown to improve mortality. The mainstay of therapy includes aggressive blood pressure control, AFib control, and diuretics for patients with evidence of fluid retention. Finally, we arrive at stage D heart failure, which describes patients with refractory heart failure requiring specialized interventions. For these patients, VADs and heart transplantation are among the options of last resort and should only be considered in carefully selected patients. Congrats! You're officially an expert on heart failure. Well, almost. In our next and last sketch in this series, we'll talk about what to do when your heart failure patient comes in with an acute decompensation of their disease. See you there!